Good afternoon, everyone, and a very warm welcome to the very first episode of Stewarts Soundbites of 2026. I mean, it feels ridiculous to say that we're to the 20th of January already because there are 17,000 days in January. But here we are. We've nearly done it.
Not yet.
Um, Welcome everybody, and thank you so much for joining us for another episode. Um, so today we are really lucky because we have two guests. We have Patrick Boyd, who is a clinical director, registered case manager, and registered social worker. And we have Ben Townsend, who is a partner and the head of the PI team at Stewarts in Leeds. So, we had a meeting last week to kind of talk about how we refine the content for this episode a little bit because we are aware that we could probably talk about this for days, as with most topics we cover on this series, actually. But we've done our best to narrow things down and hit the hot points for you. And the focus is going to be on kind of providing practical tips. We love all the top tips, Patrick, for clinicians working with brain injury survivors to maximise social care provision. And we're talking about kind of the challenges of securing local authority funding for clients whose disabilities don't fall squarely within the parameters of the Care Act. I've been doing homework on the Care Act since we spoke last week. Um, and there's loads to talk about, but we're going to zip through. Anyone who's watching, if you have any questions as we go through, please feel free to pop them in the Q&A box, and we'll get to them if we possibly can. And if not, we'll pick up afterwards. Some of you will already know Patrick because he has launched with Ben Maram his very own podcast, Listening First, which is all over LinkedIn. It's really good. I encourage you to go and find it and have a listen if you can. There's some really good episodes that have already been published. Is that a word for podcast? They've been put out there into the ether, and there are more coming. But anyway, back to the topic of today. Patrick and Ben, thank you very much. And Patrick, but just to start off, because when we initially talked about this, we were talking about kind of wider statutory provision, and I wanted to draw the distinction, and I know that everyone will probably know this, but just as a starting point, can you just differentiate for us, please, between kind of NHS provision versus local authority funding, the kind of key differences, and let us off a little bit by talking about when the need to consider local authority funding is triggered.
Yeah, absolutely. First of all, thanks very much for having me on. I'm really delighted to be with you today. So in terms of NHS and statutory social care provision, the key distinctions are NHS focuses broadly on health, so diagnosing, treating, and managing medical conditions, whereas social care focuses more on function and independence. So that's supporting people with daily living, with safety in the community, with their well-being and their participation in society in general life. So that's broadly kind of what the purpose and the focus of each are, but there's some key distinctions in terms of access and funding as well. So when we look at the NHS, the whole ethos of the NHS is that it's free at the point of use for anybody who has needs, whereas social care, it's not quite that straightforward to access. So with social care, it's means tested. So that means that there'll usually be a financial assessment and an eligibility criteria applied to anybody trying to access the services. And that's simply because the resources available are just not sufficient enough to give everybody everything they need all of the time. And so there has to be a way of kind of gatekeeping those public resources to make sure those in the greatest need are given the support that they require to remain safe and independent. So, yeah, in terms of entitlement, the NHS has a universal entitlement based on clinical need that's assessed by medical professionals, whereas social care, there isn't an automatic entitlement to services. There is an automatic entitlement to assessment, though. So anybody over the age of 18 who has any kind of social care need is entitled to request and access an assessment of their social care need under the Care Act.
And can anybody request that? Patrick, can anyone make that request for an assessment? It doesn't have to be a clinical person.
No, so yeah, anybody can request that. So usually, the way that these things are done is that a person or so an individual or a family member would get in contact with the local authority if they had concerns about a person's ability to manage safely, and that would trigger an assessment. But there are other instances where professional referrals might be made, such as via the police or the ambulance service or the fire service,
Yeah.
or medical professionals if they feel that a person has needs that sit outside of NHS provision.
Yeah, presumably it's much easier to, I mean, presumably someone is on the back foot, right? If they have a family member or somebody kind of that doesn't have a clinical background referring into this kind of assessment because there's certain way, presumably, to present information within the assessment to maximize. Well, we'll come to that. I'm jumping ahead, aren't I? We're jumping ahead, but um the eligibility criteria as well in terms of local authority funding is hugely complicated because different streams of income are treated differently for the purposes of assessing eligibility.
Yes.
And I did an episode, this is a whole episode in itself. So I did an episode on this with a community care lawyer that we'll link to this episode for anyone that's interested in that. But just let's talk a little bit about the Care Act, Patrick.
Mm.
And we're going to bring Ben in shortly to talk to us a little bit about how this kind of all links in with claimants who have litigation claims. But I wanted to touch upon the Care Act and the eligibility criteria in there because not everyone kind of fits squarely within
Yeah.
that.
Yeah.
And what I'm interested in as well, so I'm asking about five questions in one, is whether someone's eligibility for this type of funding changes as recovery kind of evolves.
Mm. Yeah, absolutely. So let's start with the Care Act in itself. So the Care Act was it was enacted in 2014, but it didn't actually come into effect until 2015, and it superseded quite a number of other pieces of legislation, including but not limited to the National Assistance Act of 1948, Chronically Sick and Disabled Persons Act of 1970, and the NHS and Community Care Act of 1990. And what it did was it took lots of piecemeal pieces of legislation and brought them all together under one piece of legislation. It was designed to be a nice, clear way of making sure that people's needs are met in the community via social care. So it was designed to create a single modern legal framework, but embedded something called the well-being principle at the heart of care provision. Now, well-being was not a factor in previous legislation, but it's very much central to eligibility under the Care Act. So the way that the Care Act works is it sets out basically 10 outcomes under which a person is assessed, their needs are assessed. Those are they are prescriptive. It's a set 10 outcomes, and there's no kind of wiggle room in terms of what else can be included within the assessment. Those 10 outcomes are around managing and maintaining nutrition, managing personal hygiene, managing toilet needs, being appropriately clothed, being able to make use of their own home safely, maintaining a habitable home environment, maintaining and developing relationships, accessing work and education, using facilities or services in the community, and finally, performing any care and responsibilities that they may have for a child. So they're the 10 outcomes that are prescribed in law that the local authority must assess a person's needs in line with. Now, in terms of eligibility, there's three main criteria. The first is that the person's needs need to arise from a physical or a mental impairment or an illness, such as mental health or learning disability, autism, dementia, chronic illness, or brain injury in the case of my work. And then out of those 10 outcomes that I've just listed, the person needs to be unable to achieve two or more of those outcomes. And then finally, in terms of the well-being principle, there needs to be a significant impact on that person's well-being as a result of being able to meet those two or more outcomes. So that's having a real life impact on that person's dignity, autonomy, their mental health, the safety, and the participation in daily life. So when a local authority comes to assess a person's needs, those are the three things that they're going to look at. And that means that we're essentially using a one size fits all approach to assess anybody's needs over the age of 18. Now, that doesn't work broadly when you're looking at a range of people with so many varying needs. A good example is the kind of clients that I work with are usually quite subtly brain injured, so their impairments aren't obvious. And some of their impairments aren't obviously physical either. So the outcomes that I've listed there, they are quite heavily focused on physical abilities, and they don't necessarily always lend themselves to exploring a person's executive dysfunction or their cognitive skills and abilities. So that means that when completing an assessment with a person with those kinds of difficulties, you need to be really creative about how you explain and evidence that person's difficulties so that they fit within the outcomes of the Care Act.
Which is easier when you are a person, when you're a case manager or a clinician or a person like that, but it's presumably much harder for a family member to do.
Much harder, yeah. And I think one of the real challenges, especially again for people with neurological injuries and brain injuries, is that there isn't necessarily a broad understanding within the social work practice of brain injury and how it affects somebody. That is changing. It's something that we're trying to address, but brain injury is not something that's taught generally across the board in social work education. So we can't rely on social care practitioners always having that understanding of some of the subtle difficulties that a person might experience.
Yeah.
So the onus is on us then as professionals and as family members to get that information across to the assessor.
There's quite a huge responsibility, really, especially, for people without claims that don't have case managers and someone in their corner like that to disseminate that level of education is hard, right?
Yeah.
And it kind of leads into my next question, Patrick, which is about kind of whether you've seen it, in your experience of doing this work, both as a case manager and a social worker, whether you've seen kind of a disparity in how local authorities approach this process, not just with it, between local authorities, but between kind of individual social workers. Presumably, there's a huge discrepancy.
Yeah, always. So yeah, local authority to local authority, it does depend because of the level of resources available and the systems and processes that they have set up. But I would say more so from individual to individual assessor, because it does rely on the assessor having an understanding of the difficulty that the person's living with that they're assessing.
Yeah.
So I would say a social worker with a background understanding of, for example, acquired brain injury is going to be able to perform a far more detailed and accurate assessment than a social worker without that baseline understanding.
And how long would it take, Patrick, for a local authority to determine what they might be willing to provide, or does it vary hugely between different authorities?
I think again it varies. It varies between local authorities and on the assessor and how quickly they're able to process the assessment. Unfortunately, because of the nature of social care, social workers are often under immense pressure with caseloads that are frankly unmanageable, and so assessments aren't necessarily conducted in a way which might you know achieve the best outcome all of the time.
Yeah.
Just because they're trying to get through these assessments,
Yeah.
which is a real challenge, and I really empathise with our social care colleagues over that because it's just not an easy job at
Yeah.
all.
Yeah. Ben, just to come to you. So I wanted to talk a little bit about because this applies to, a lot of case managers, things that are working where there's active litigation ongoing. So I wanted to talk about how important or not it is to apply for or secure local authority funding in litigation cases. So even if there's interim funding available, is there any benefit to applying? Is the process of applying helpful? Do you have a
Well,
thought on the system?
I mean, it's a great question, if I may say so. On one level, you might say, well, if the point of a compensation claim is to obtain full compensation for an injured person, why on earth would you go to somewhere else other than the defendant's insurer looking for money? Surely the defendant's insurer should be your first port of call for all the money that the claimant needs. And the answer is there are a number of reasons why you might look to, say, a local authority or to the NHS for funding for care, which is such an important part of a compensation claim. For instance, it might be a case where liability is not going to be 100% for the claimant. It may be a case where you're only going to recover a proportion of the value of your case, and you might need input from statutory services on that basis towards the cost of the care that the person's going to need. It may be that even though it is a 100% claim, where you're going to recover ultimately, in theory, all of the money from the defendant, may be that you investigate what's available through statutory services, because that may be a source of negotiation with the other side. If there is money available through statutory services, then maybe there's a deal to be done through a reverse indemnity of some description as part of the ultimate settlement of the case.
And presumably the process of applying, and as Patrick has said, that those care act provisions are pretty prescriptive, and kind of Patrick will talk about this as the final question next, but with clinical people and case managers providing justifications as to how their clients might fall into one of, the parameters of this act in more nuanced and subtle ways. Presumably the production of documents and everything around that process is helpful to litigation as well.
Yes, I mean that's absolutely right, Em. The process of assessing a person's needs, setting out what they are, can be helpful in providing evidence of what the injured person's issues are, both through the documentation produced by the rehabilitation team, the case manager, and by assessments by statutory services as well.
Yeah. And so, Patrick, to round us off, what we're, no pressure, but what we're on are the big kind of top tips that we're after, and also just if you can briefly, touch upon when this process should start. When we should look at trying to evidence need, and practically how clinicians working with people who are brain injured and might not fit within these kind of physical prescriptive parameters of the Care Act, how people go about securing local authority funding from an early stage.
Yeah. So in terms of evidence in need, first and foremost, the process, I believe, starts right at the beginning of your involvement. As a case manager, I'll be thinking about the Care Act and the outcomes of the Care Act and that person's well-being right from the point of my immediate needs assessment. I won't necessarily set it out in the same way, but I'll certainly be thinking about how this person's needs would fit within the outcomes of the Care Act and whether that person's eligible, and how I would support them to access that support in the future if necessary. You asked earlier, Emma, about a person's changing needs. I think the answer to that is yes. People's eligibility for support changes over time, absolutely. So a person's recovery and progression might reduce their needs, or a deterioration in their condition might increase their needs. For that reason, the local authority must review a person's care and support regularly when they're involved. But the local authority absolutely has a duty to assess a person's needs as and when they're presented to them under the Care Act. So in terms of practical tips, I think being really specific about the impact of a person's impairments and difficulties on those specific outcomes and how that impacts on their well-being. So that needs to be very clearly documented within records, within notes. It can be evidenced through GP letters and session notes and discharge reports, and all sorts of the documentation that we gather in on a day-to-day basis within private rehabilitation. I think it's really important to clarify also what would happen to that person if they didn't have the support that you were advocating for them, because I think that really helps to underline the impact on that person's well-being. So the well-being of the person has to be central to the request for support. Documenting risk and documenting fluctuations and explaining why a person might have a good day, but how that isn't necessarily reflective of their overall presentation on a day-to-day basis. So not focusing on just a good day, not focusing on only the bad days, but giving a really accurate reflection of that person's usual presentation and experience. And using functional language. The assessors that are completing these Care Act assessments aren't always equipped with the understanding of a person's condition. So helping that assessor to understand the functional impact of the person's difficulties on them on a day-to-day basis really helps them to frame how that difficulty impacts on their well-being.
Yeah, that's super helpful, Patrick. I've got a question in the Q&A box, if you don't mind, and I think it's a really good one. The brain injury needs indicator tool can be helpful, but most social workers don't know or seem to want to know. Can we suggest they use it to ensure no neglect of duty of care, morally, not legally?
Yeah, absolutely. I mean, the brain injury needs indicator is an excellent tool, and it is actually named within the statutory guidance of the Care Act. So it is something that social workers should be using. However, I teach at one of my local universities quite regularly, and I know that the brain injury need indicator isn't something that's taught automatically within social work education. It's not flagged, and I'm not sure how aware people within local authorities are of the tool either. So there's definitely more to be done there in terms of raising awareness. The tool essentially encourages the assessor to triangulate information and make sure that they're not just gathering from one source, which is a marker of a good assessment anyway. We shouldn't just be taking information from one source, but it's a really nice, clear, structured way of gathering that information. So yeah, I'd strongly recommend any case managers or rehab professionals working with local authority partners bring it up and suggest the brain injury needs indicator to them and encourage them to use it.
Yeah, encourage slash. No, I'm joking. Perfect. Thank you so much, Patrick. I've run over as usual. I was determined this year to be better at trying to keep within our time scales, but I failed miserably on the first attempt. But we
another broken resolution.
I know. Well, one of many, frankly. And I've just got another comment, so I'm going to read it and to pot with it. From Miranda, which says, I've had a case that social services accepted the client has agreed needs, but found that the family could provide it and refused to help. Any tips around that?
Yeah, I've come across that before. The local authority aren't actually they can't require families to fill the gap. They can't expect that of families. So I would be challenging the local authority on that. There can't be an expectation that a family would fill the gap. But sadly, local authorities do sometimes recognise that a gap can be filled, and especially if a family are willing to do it, then that seems like the most straightforward solution. But I don't think it can be I don't think it can be a given. So I would definitely be going back to them and challenging them on that, because what if something were to happen to the family, or what if actually the family providing that care isn't within the wishes of the person receiving care and support? It's not as straightforward as them just being there to fill a gap because it suits the local authority.
Yeah, and I think there are some community care lawyers that offer assistance to families on a pro bono basis, which I'll look into a little bit more. But that could be helpful. One more question. I say one more. We'll see how we get on. I'm really sorry, but really good questions and engagement, Patrick. Someone's asked, what is the eligibility for 24-hour care funding?
Yeah, well, I think it comes down to the nuances of the actual assessment. So, um, without understanding kind of the specifics of any case, any one case, I couldn't say, but I think it would require quite a significant number of the outcomes under the Care Act to be flagged. Like I said earlier, the eligibility is two or more of those outcomes. If someone's requiring 24-hour care or support, you would expect that quite a number of those outcomes are hit. Or if only a couple of them are hit, then there's quite a significant impact on that person's well-being if they don't receive that 24-hour support. So it comes down to the detail that's included within the assessment and the evidence that's provided to support the recommendation.
And I guess that if there is such a significant need that somebody requires 24-hour care, it might be a health-related need in any case that they might be looking towards the NHS to provide input on.
Yeah, and that's par for the course now. I think within most local authorities, there's always the request to complete a continuing healthcare checklist to see whether some or all of that person's needs can be met through continuing healthcare as well, which is another topic in itself, as you mentioned earlier, Emma. But yeah, there is that tension between social care and healthcare, and when 24-hour support is in play, then there's always going to be those questions raised.
Yeah. Someone says the family can also request a carers assessment if they haven't already. And that was something I'd planned to ask you about in the session, but believe it or not, I cut it out because we were talking too much. But that's absolutely right. There can be a carers assessment requested. And Sue has asked, Patrick, can the local authority set a financial limit on the care they will provide?
So the local authority will usually set out a budget for the person's care based on their assessment. So it will give an indication of how much they would expect a person's needs to cost. But my understanding is that's not prescriptive; it's a guide. Local authorities will always try and find the most cost-effective way of delivering support, even if to those of us on the ground with the client think that actually that's not the best for the client. There is that, again, that tension between the delivery of care, what's suitable for the client and what's affordable and manageable and proportionate from the local authority's point of view.
Yeah. Thank you so much, Patrick. I'm really sorry I've kept you much longer than I intended to, and I've kept everyone else watching much longer than I intended to, and I'm very sorry. But I'm really glad because we've had a really useful discussion. I hope it's been helpful for everyone watching, and I thank you very much, Ben and Patrick, and everyone joining for your time. We'll be back in February with another episode, the details of which will be released very shortly, and we hope to see you soon. Thank you.
Thanks, everybody.
Thanks. Bye.
Cheers.